So pediatric surgical emergencies are very, very different from adult surgical emergencies. Now, we all know that we are afraid of dealing with little children, and just make sure that the surgical conditions that you see in adults are very different. Okay. So just remember, in children, constipation is never an emergency. Okay. Never refer a patient to the pediatric surgeon on a Friday evening with constipation. Okay. Now, what is the most important pediatric surgical emergency anywhere in the world? Okay. Right? Any country you live in, anywhere you are, right? For pediatric surgeons, the most important surgical emergency is neonatal bilious vomiting. Okay, so if you hear, right, that a small baby, a neonate, is vomiting bile, right, the clock starts ticking, and you've got about 6 hours before you can save the life of the baby. Okay, so just remember, neonatal bilious vomiting is an absolute surgical emergency until proven otherwise. Okay, so I'm sure you understand what a neonate is, and I'm sure you understand what a bilious vomiting is. Okay, so do you know the color of bile? Right, it is dark green. Okay, if a baby is vomiting bile, it's an absolute surgical emergency. Okay, and this condition is so important that today I'm just going to divide my talk into 2 portions. The first portion is all the emergencies, and I will talk about the bilious vomiting in the second part of the lecture. Okay. Okay, can you understand all this? Can you understand all this? Okay, fine. So, so why is it an emergency? Okay, neonate bilious vomiting. There are so many causes. I know, right? There are so many causes, but the most important and the most lethal cause is what we call malrotation with volvulus. Okay, so a child is born with malrotation and then it volves. Okay, so what is this malrotation? What is this volvulus? It is a malrotation and volvulus of the midgut. Okay, do you know where the midgut starts and ends? Right, midgut starts right at the duodenojejunal flexure up till the right 2/3 of the transverse colon. It is supplied by the superior mesenteric artery, right? And if there is volvulus of the midgut, right, the superior mesenteric artery, the blood supply is absolutely totally cut off, right? So you have got the dead gut, right? Completely dead gut from the duodenojejunal junction up to the right 2/3 of the transverse colon, right? If that whole midgut dies, right, and mind you, we are talking about a neonate. It is not compatible with life, right? For you and me to survive, right, we have to rely on the gastrointestinal tract, right? And if the whole of the midgut goes into volve, the whole midgut dies, it is not compatible with life, and the baby dies. Okay. And so as soon as you suspect, you do the investigation and you do an emergency laparotomy and you find a condition like this. So as you can see, right, in this picture, all right, this is the midgut and it is completely twisted. You can look that the bowel is still viable at the moment, but we are looking at only 6 hours before the whole of the midgut dies and it goes necrotic. So these are some of the operative findings. On the left side, you will see malrotation with volvulus. part of the midgut is gone, right? However, the baby is lucky because some of the midgut is surviving. All right, so you can take out the dead gut and you can pull out a stoma, and then you can close it at a later date. However, if you are not careful and you do not take the child to theater as an emergency, right, and if there is any delay in diagnosis, this is what you see, right? This is the whole of the midgut that has gone necrotic, right? And if we see a situation like this on table, yeah, we take it out, we just close it and let the baby continue with the palliative care, because it's a neonate, it is not ready for transplant or anything at all, and the baby dies. Okay, now, if I have not scared you enough, I will scare you even more about this condition in the second part of my lecture. The second part of my lecture, I will talk only on malrotation with volvulus, so there is some more. Okay, so far now, can you understand? A nappy rash is not an emergency, so don't rush these babies to the pediatric surgeon. But what is a surgical emergency in children is testicular torsion. It happens in adults as well. However, it happens very, very commonly in children, right? So because I couldn't put a child's testicle photo of a genitalia, this is more or less a bit of an adult with pubic hair. However, we are talking about babies and children. Right? Testicular torsion in babies and children, it lasts maximum 6 hours. It completely twists. So you've got to go in as an emergency. Otherwise, you lose the testicle. This is not very different from adults because adults do the same thing. However, what we need to know is that when a child presents with features of testicular torsion, right, there are 3 features of testicular torsion, right? Pain, redness, and swelling. You do not do any ultrasound scan. You do not do any investigation. You take the child to theater straight away. You just untwist it. Fortunately, unlike in adults, it is very, very rarely associated with cancer or any other condition. So we take the child to theater, untwist it, and fix the other side, no matter what time of the day or night it is. Now, because we are talking about babies and children, there is a condition called the neonatal torsion, right? Or perinatal torsion. The baby comes out of the mother's womb, either with the elective cesarean section, emergency cesarean section, or vaginal delivery. And as soon as the baby is out, when you do the baby check, the baby has got red, swollen, tender testicle anyway. That is a neonatal torsion or perinatal torsion. In perinatal torsion, you do not have to take the child to theater in the middle of the night as an emergency, because this happened in utero just before the delivery. So whatever you do, whatever you take the child to theater, you cannot salvage this testicle anyway in a perinatal torsion. So you can leave it alone, take the child to theater in the morning. But apart from that, all other conditions of painful, red, swollen, tender testicle needs to be taken to theater as an emergency. Hydrocele is not a surgical emergency. However, we do see this incarcerated inguinal hernia very commonly in babies and children. And on the right side of the picture, you can see the inguinal hernia, which is stuck. In adults, you may wait for a while and things like that. In babies and children, the inguinal canal is very, very small. The deep ring is very small. The superficial ring is very small. So if the hernia becomes stuck, it becomes obstructed and strangulate it very, very quickly. So you don't take the chance at all. So I know that adult surgeons will tell the patients, well, my waiting list is about 3 months. Come back in 3 months. I'll put it on your list in 3 weeks' time. But if you see a baby or a pediatric inguinal hernia, even if it is reducible initially, you don't take any chances. Even if it is reduced, I will put all these children on my list, either as an emergency or an urgent elective the next morning, and I'll fix it. Because it's very, very common, it's very, very easy for pediatric inguinal hernias to become obstructed, strangulated, and cause a lot of trouble. And then in babies, they lose the bowel very quickly. And also another thing is that because it's a tiny baby, the inguinal hernia operation for an obstructed hernia, it can, the vessels are very, very small, and the testicle goes dead very quickly. So in pediatric inguinal hernia, even if it is reducible, don't take any chances. The child should be operated the next day, which is very, very different from adults. Okay, now continuing along the theme of genitalia, right? Many parents bring their children to GPs or to doctors saying, oh, look at my son's penis. I can't retract the foreskin. I can't retract the foreskin. What do we do, right? So all children, or almost all children, have got a condition called the physiological phimosis. The name itself explains everything. It is physiological. It is not pathological. So all children, almost all children, they can't retract the foreskin. It's okay. Right? So your next question will be, when should a boy be able to retract the foreskin? When is the normal age for the foreskin to be retracted? Okay, the answer is day 0 to 12 years of age. As long as it is not giving any trouble, we do not jump onto circumcision or do anything at all till the child is 12 years of age. And I'm talking about physiological phimosis. If between day 1 to 12 years of age, if a child has got problems, symptoms, such as recurrent balanitis, or if a child have got documented urinary tract infection, or if a child has got scarring of the foreskin called the balanitis xerotica obliterans, yes, we do not wait till 12 years of age. We go on to do the circumcision. What I'm trying to say is just pure, simple. The only problem of inability to retract the foreskin before the age of 12 years is absolutely normal. So don't have to do anything about it. Don't panic. And as the baby is saying, leave him alone. So this is talking about phimosis, right? Let me go on to paraphimosis, right? Paraphimosis is a different condition, right? So when does paraphimosis occur? When boys usually have the peer pressure, starts going out with other boys, they start comparing, and then one boy, bigger boy, will say, look, I can do this, you can't do that, and then they forcefully try to retract the foreskin. Okay, and if trying to retract the foreskin itself is not a good condition, but if they retract it and doesn't push back, what happens is that the tight foreskin becomes stuck at the corona, and it causes paraphimosis. So what happens when the foreskin gets stuck there? Right? The venous return is affected first, and it just starts swelling up, And before you know it, you see a picture like that, which is very, very painful, right? And by this time, the child cannot push the foreskin back. And even the bravest of the children will run to their parents and say, "Mommy, Daddy, I don't know what's wrong. I did nothing at all, but it is very, very sore." So yes, we don't like paraphimosis, although phimosis is okay because it is strangulating the blood supply, and that is why it is very, very, very painful. So if you see a condition like this, right, a lot of the time in the emergency department, we can put some soaked water, sugar-soaked water there, just to reduce the edema and try to push it back in. It happens in adults as well, but in children, we've got a very low threshold for taking these children to theater because we don't want to reduce this paraphimosis without anesthesia. It is very, very painful, and we don't want them to remember this at all. So we have a very low threshold for taking these children to theater to reduce under general. We do not do circumcision in the same instance. We let them recover, and then we see them in the clinic. And if the foreskin is very tight, and we will offer a circumcision. So just be very careful when you are examining the genitalia in the emergency room, whether you are dealing with a phimosis or the paraphimosis. As I said before, physiological phimosis is normal up till the age of 12 years, and paraphimosis is abnormal, whatever the age of the child is. Okay, any crying child is not a surgical emergency, right? Children cry for a variety of reasons, so you don't need a pediatric surgeon. However, in children, a very common cause of very excruciating crying is a condition called the intussusception. It is very, very common in children, right? It's otherwise healthy, normal child, right? Where the proximal part of the bowel intussuscepts or telescopes into the distal part of the bowel. So if you cut it, right, it looks like this. Right. So when intussusception occurs, right, the baby starts really screaming, right? They have vomiting, they start screaming because the peristalsis is trying to overcome this obstruction. However, it is a vicious cycle because every time the peristalsis tries to overcome the obstruction, it pushes this bowel more and more distally, and the child becomes more and more unwell. So how do they present? One, excruciating pain, right? It's not just the cry of a hunger, or when the child has dirtied its nappies. It's a very, very severe cry. They vomit, and before you know it, there is progressive abdominal distension. Now, you need to bring this child to the pediatric surgeon commonly, because it's very, very rarely it's going to get better on its own. So what does the child need? The child needs, don't forget your basic ABCs, the airway, breathing, circulation, right? You may be thinking this is not trauma. Why should we bother about the ABC? Remember, in children, whatever the condition is, you always start with an ABC, especially in children. Why? Because of vomiting, any child who is vomiting, they can't protect their airway very well, and they can aspirate, and they can even die. So you've got to clear the airway, the breathing, circulation, put cannulas in, because there is a lot of vomiting, there is fluid and electrolyte loss, and this is an acute loss, right? They lose a lot of fluid and they lose a lot of electrolytes very, very quickly. So you just have to resuscitate the child appropriately and put the NG tube down. And as soon as the child is stable, you take the child to radiology to do an ultrasound scan. And the ultrasound scan will confirm the diagnosis of intussusception. And as soon as the diagnosis is made, what we do here is what we call the air reduction of intussusception. We put a tube down the baby's bum, we close it, and we put the pressure under fluoroscopy guidance. We push the air to unplug this, right? So you can see it under the fluoroscopy vision that this intussusception goes back and back and back and back up till where it started. A lot of the time, it is successful and we don't have to do anything else. However, if we use too much pressure, right, the bowel can perforate. So the pediatric surgeon must always be in attendance where there is an air reduction of intussusception going, okay? And if, of course, the air reduction fails, you've got to do a laparotomy and do that. This is also another condition where situation awareness is very, very important. Okay, you don't, you don't leave this child to be sorted out till the next morning. You just do it as and when. You've got to call the consultant radiologist to come in the middle of the night. You've got to come in whatever time of day or night it is, and you've got to sort it out. So be careful of intussusception, because let's say you miss this condition, what will happen, right? This child, within a few hours, this child can die from a variety of causes because they vomit very strongly, not just because of the obstruction. Yes, you may think that, oh, obstruction, people vomit anyway, but this child has got a very strong vagal reflex. So it doesn't have to wait for all these bowel loops to dilate before the child vomits. Even from the first instance of intussusception, as soon as this loop of the bowel goes in, the child starts vomiting because of the vagal reflux. So the bowel doesn't have to dilate, distend, cause obstructive symptoms. And before you know it, this child is very, very dehydrated. So if you leave it alone, wait till the morning, this child could die from fluid and electrolyte imbalance. And just remember always that a baby and a child's physiological reserves are very, very low, unlike in adults. So that is one cause of death. Another cause of death is this bowel becomes ischemic because the distal bowel starts squeezing on the proximal bowel. So it doesn't just cause the obstruction, it squeezes the blood supply as well. And that is why this gut becomes necrotic. Any necrotic gut perforates, right? And peritonitis in children is lethal in a very, very few hours. So you need to be very careful. So don't miss this condition. So although every crying child is not a surgical emergency, be aware of this condition. And if the child, you suspect intussusception, resuscitate this child very quickly, get an ultrasound scan, and do the air reduction and have a low threshold for taking the child back to theater. And again, this is more relevant to our practice. Don't tell the surgeon just to look at an x-ray. Don't tell the parents the surgeon will operate the baby immediately. And don't tell the child you can have something to eat, because they might need nil by mouth. Now, you must be thinking, why am I not talking about other conditions? Appendicitis, yes, appendicitis is important in children, but it's not very common. Under the age of 12 is very, very rare because the base of the appendix is quite wide. So although in adult practice, you might be seeing appendicitis very often, we don't see this very often. And even if a child presents with appendicitis, it is not life-threatening. You can resuscitate the child, you can operate the child the next morning. intestinal obstruction from other causes apart from these two conditions that I have mentioned, the inguinal hernia and intersusception, and malrotation, right? They can wait, right? You do a fluid electrolyte resuscitation, you do an X-ray, right? You resuscitate, you think about it, you have your cup of coffee, right? You finish your lunch, right? You drive in, you do the operation, it's okay, right? And that is why I'm not going to go into the other causes of intestinal obstruction. Hypospadias, hydronephrosis, right? They never need urgent intervention unless the hydronephrosis becomes pyonephrosis, in which case the radiologist will do a puncture. So in summary, for the first part of the lecture, right, just because I'll be talking about the bilious vomiting in my second lecture, right? Bilious vomiting, never sit on it. Testicular torsion, very important. Incarcerated inguinal hernia, go in. Paraphimosis, go in. Intersusception, go in. So unlike in adult practice, these are the things that you need to go in. You need to have a low threshold of suspicion, and then you need to go in as soon as you can, and you need to sort it out. Very different from adults, but I hope I have summarized enough. Thank you very much. And that is only the first part of my lecture. So I have told you in the first part of my lecture, a neonatal bilious vomiting, which is one of the causes of malrotation with volvulus, which is a very important condition. So I'd just like to tell you a little bit more about malrotation and volvulus. Okay, so just relax and listen. You don't need to remember any of this, right? So when you talk about the embryology, right, when a baby is developing in utero, right, there is a phenomenon called the physiological herniation of midgut. Yeah, listen to it carefully, because the name says is physiological herniation of midgut. Because it's physiological, it's normal. Okay, so if you look at the developing embryo, right, the development of the midgut is faster than the development of the abdominal cavity. So there is not enough room in the peritoneal cavity for the developing gut to grow. So the gut has to go out into this umbilical cord, right, to grow. And then because it grows faster than the peritoneal cavity, then what is going to happen is at some point, the peritoneal cavity grows, it's got enough space, and then it tells the gut, okay, I've got enough space for you, come back. And then all the bowel loops, the midgut returned into the peritoneal cavity, gets fixed. And that phenomena is called the physiological herniation of the midgut. So it herniates, it rotates, it twists, it retracts, goes back in, and it gets fixated. When does it begin? It begins at the 4th week of intrauterine life, and everything goes back in, right, by the 12th week of life. And during this process, there is the twisting of the bowel, right? Because our bowel, if you look at the adult bowel or a child's bowel, when a baby is born, is not straight tube anymore, it's coiled. But it's not randomly coiled. It is coiled very specifically, and it twists, right? 270 degrees counterclockwise, it twists and then goes back, right? 90, 90, 90, and it twists around the superior mesenteric artery. It goes back, and that is the physiological herniation of the midgut. So if you look at a baby, of course, this baby is already born, but before the baby is born, this rotation occurs counterclockwise, right, in relation to the baby and in the physiological herniation. So normal is counterclockwise, but if there is malrotation, if the bowel is twisted, it evolves clockwise. So in theater, when you go in, you've got to correct counterclockwise. So counterclockwise is normal, and if there is volvulus, it twists clockwise. So your job is to untwist it counterclockwise. So I just talk about rotation all the time, right? Rotation counterclockwise, 390s, 270 degrees, right? Rotation is always associated with fixation. If proper rotation doesn't occur, fixation doesn't occur, right? If fixation doesn't occur, the bowel is too mobile, right? If the bowel is too mobile, it can twist, and that is what causes the volvulus. So this is normal. You don't need to know, I'm not going to go into that in detail, but you all know this diagram. After a proper rotation and fixation, the bowel looks like this. You all know this. But there are two areas of interest for the pediatric surgeon, right? The duodenum, jejunum. Where is the duodenojejunal flexure? That is a very, very important point, reference point for every pediatric surgeon anywhere in the world. That is the duodenojejunal flexure. Another second point, which is very important, is the terminal ileum, right? Where is it? So whenever we do a laparotomy, right, we always determine where's the DJ, where's the terminal ileum, right? If they are not, that is our two reference point. When we get that two reference point, we can work on it, right? So till we get these two reference points, right, we don't know what is where. So just be mindful that the duodenojejunal flexure and the terminal ileum, right? And another very important thing about these 2 points is that the root of the mesentery runs from the duodenojejunal flexure to the terminal ileum. That is the root of the mesentery, right? And as you all know, from the root of the mesentery pans out and wraps the whole of the small bowel. And this is what I'm talking about, normal. So this is what it looks like, where a normal rotation occurs, normal fixation occurs, where the DJ is here and the terminal ileum is here. So this is normal. So let's talk about what is abnormal. So if this counterclockwise rotation, right, as I said, is 270 degrees in total, doesn't complete, if it gets arrested at any point, it is called the malrotation. If it doesn't rotate at all, it is a malrotation. If it doesn't finish to 270, it is malrotation. And then mixed rotation, everything, right? Unless it's a perfect 270 degree counterclockwise, everything is malrotation. We are not talking about reverse rotation, which I will talk about if I have the time. So now what happens in malrotation, right? So if it has not twisted properly, right? So the DJ is here, terminal ileum is here. Now, if it hasn't twisted properly, if you look at it, the DJ is here, the terminal ileum is here. It ends up like this, right? So if you look at the root of the mesentery, it's very narrow and they are abnormal bands. So two things happen. The root of the mesentery becomes very narrow and there are large bands. So this is what it looks like that. The DJ is here, right? The terminal ileum is here, right? There are large bands, and from that very short mesentery, the bowel twist, right? Causing a volvulus, right? So this is a normal broad-based mesentery. This is a small bowel, unlikely to twist. In malrotation, the base is very, very, very narrow. It pans out, the whole of the small bowel is here, so it is very prone to twisting. So that's why malrotated bowel is very, very prone to twisting. And if it twists, the whole of the midgut goes, and the midgut is from the DJ flexure to the right two-thirds of the colon, which goes necrotic. Can malrotation and volvulus occur antenatally? Yes. If it occurs antenatally, it causes bowel atresia, right? If the malrotation, so if a baby is born with malrotation, you will never notice at all. The baby, the child, the adult may live till he dies, without any manifestation at all. However, they can have acute obstruction from large bands. They can have chronic obstruction from large bands. Large bands are the abnormal bands from the abnormally placed duodenojejunal flexure to the abnormally placed terminal ileum. It can cause chronic valvulus, and the most important thing is, of course, the acute volvulus. 1% of the population have got malrotation. You might be walking with a malrotation, so be careful, check it out. Right? 1 in 6,000 will present with clinical symptoms, and 10% are found incidentally. Right? Sometimes I do upper GI contrast study for every peg gastrostomy that I do, every fundoplication that I do, and then when I do the contrast study, sometimes the radiologist will ring up and say, oh, by the way, this child has got malrotation. So just be mindful that not all malrotation can cause volvulus, but they are very, very prone to volvulus. Malrotation is normally associated with other conditions. Congenital diaphragmatic hernia, they always have malrotation. Anterior abdominal wall defects like the gastroschisis and exomphalos have got malrotation. Duodenal atresia, biliary atresia, some anorectal malformations, some cardiac anomalies, some heterotexy syndromes. So just be mindful. Most of the time they twist and they present at the first month of age. 90% will present the first year of age, but they can present at any age, right? I think you guys are all very, very young to remember the Bee Gees. Does anybody remember the Bee Gees group? Anybody? Or maybe you're too young, right? Bee Gees is a very, very famous band in our days, and one of the Bee Gees guys, right, died from malrotation with volvulus at an adult age, right? What do they present with? It is a sudden onset of bilious vomiting in a healthy, growing child. This is sometimes a very sad thing because these kids initially are not sick kids. They are lovely, lovely kids. They've got nothing wrong with them whatsoever. They're just running around. They are just bouncing around. They are giggling. They are laughing. They are sleeping. And all of a sudden, right, it twists and then it causes this bile, right? So that is a sad thing about these conditions. So don't wait for this baby child to deteriorate. Oh, the child is fine. Yes, the child is fine because the child is giving you the window of an opportunity to go and sort it out. So if you see one green vomit in an otherwise healthy growing child, even if the baby looks completely normal, your clock starts ticking. Every second counts. This child belongs only in one place, and that is a pediatric surgical center or any center or anywhere that can offer this child a proper investigation and an intervention. These are very late signs: bleeding PR, abdominal distension, hypovolemia, acidosis, shock. So it's very, very sad when some people say, oh, the child had one bilious vomiting. Let's wait and see. Don't wait and see. The baby is giving you the opportunity. Don't wait for these late signs to develop. Just rush this child, rush this baby to a pediatric surgical centers. If we have got enough time, if we've got about half an hour, right, we will do a upper GI contrast study, which is the gold standard of investigation in malrotation with volvulus. You do a contrast study and the stomach, the pylorus, the duodenum should go to this other side. The DJ should be on that side. But if you see the contrast just coming down like this, right, within the next 10 minutes of this X-ray, this child's abdomen should be open, right? Maximum half an hour, right? In my hospital, right? Everything else will stop, right? You've got to open up another theater, right? I may carry the child myself to theater, right? You just need to open this abdomen now because there is a twisted bowel here, right? And In extreme conditions, if I strongly suspect malrotation and volvulus, I will not even do an upper GI contrast study. I'll take this child to theatre straight away after resuscitating. And even if I find something normal, I won't regret going in. Okay, so what do we look for in the upper GI contrast study? You look at the position of the duodenal jejunal flexure. It should be on the left side, but and it should be at the level of the pylorus. If it is not, right, don't waste time, right? What is a treatment, right? And I have put very, very clearly, every second counts, right? Rapid resuscitation, acid-base balance, antibiotics. The baby may need inotropic agents, and then the baby needs a laparotomy. You can do a laparoscopy, however, it is very, very difficult with all the dilated bowels, and it may take some time. You may injure the bowel accidentally. The best thing is to do a laparotomy. You've seen this slide before, right? And this is the operative findings. Very dangerous condition. You may see partial loss of midgut, and if you see this condition, it's better to go along palliative care. You take it out, close the abdomen, let the baby die peacefully post-operatively, rather than this baby is not going to survive. And I have told you very, very clearly that this is an absolutely healthy, normal growing baby. This is not a sick baby, so just be mindful. Okay, even if you see this condition, if most of this bowel is gone, if the baby is left about 10-20 centimeter, the baby can grow up with short bowel syndrome, which is not a pleasant condition. I don't think as non-pediatric surgeons, you need to know all the steps, okay? But laparotomy, you completely eviscerate the bowel, confirm the diagnosis, you untwist the bowel counterclockwise, okay? And then you prepare for reperfusion syndrome, good oxygenation, inspect the bowel, and then you do the last procedure, right? And you divide the last bands, because I'm talking to the general audience. I'm not going to talk about the operation in detail. If all goes well, the bowel function returns in 5 days. Some may end up with short bowel syndrome. Some may need a bowel transplant. But if most of the bowel is dead and gone, it's better, the kindest thing to do is to let the baby go, right? Mortality is very high, okay? 3 to 9% mortality. So don't take it lightly, right? Short bowel syndrome is not a pleasant condition for the child and for the parents either. You can have recurrent volvulus, you can't do anything about it. As with any laparotomy, you can have adhesive bowel obstruction, you can have intussusception, but just be mindful that mortality is 3 to 9%, and you can end up with short bowel syndrome. So if after this 1 hour of me talking to you, if there is one and only one message that you need to take, that is neonatal bilious vomiting is an absolute surgical emergency until proven otherwise. If you remember just one for the rest of your life, the purpose of this lecture is complete, because you may not be able to do anything about it. You may not be a pediatric surgeon, but if you see a baby, a child with a bilious vomiting, even if you can know that, oh, this is serious, go to the appropriate center, you would have saved the life of a child. Thank you very much. Very happy to take questions.